I want to thank each and every one of you for coming today. This is really a special day for us. And just to give you a little background on why this all came about, it was in September of last year. My wife and I celebrated our 40th anniversary with a Mediterranean cruise. And would you believe, a couple days into the cruise, we met a great couple of which the wife was a survivor. And you all know how sometimes that doesn't happen. On our cruise, sailed for the next several days, Dr. Bruno's name came up several times with high enthusiasm. So not being familiar with the good doctor and his works, I made it a point to check out his website and the Post-Polio coffee house when we returned home. Was I amazed and somewhat overwhelmed the amount of research and counsel posted on these sites. Then at our January APA meeting here, Dr. Bruno's name came up again by one of our board members, and I sat there thinking, how cool it'd be to have a survivors conference and have this Dr. Bruno enlighten us. So at the end of the meeting, I approached Carol with the idea, and she was all about it. Dr. Bruno graciously accepted our invitation, and the conference plans were in motion. 5 months later, after several hundred emails, phone calls, face meetings, here we are. This has been quite a learning curve for several of us. But believe me, it's been a wonderful experience. Thanks to each of you for making the journey to be with us today as we glean from our guest speaker, Dr. Richard Bruno. And P.S., if something seems a little out of line, please forgive us. Please forgive our rookie mistakes. This is a first. Thank you.
Thank you. I have to help somebody keep me together here. At this time, I would like to introduce to you Dr. Michael Jokelson, who is the new director here at the Shepherd Center. Many of you who are in APA knew Dr. Leslie before Dr. Jokelson, and I see some heads shaking. And I want you to know that we have a wonderful physiatrist, I have to say that right, physiatrist, who has now moved into this position here, and we will be working with more and more in the coming months. So at this time, I'd like to introduce him to you to tell you a little bit about the Shepherd Center for those of you that are new, and for those of you who have not met him yet, I'd like to introduce Dr. Jokelson.
Good afternoon, everybody. Thank you very much for inviting me to come to welcome you. Sorry for some of the technical difficulties that we've had. I'm not an IS person, to say the least, but we've got some experts here who've managed to get us up and running, I think. So it certainly gives me great pleasure to welcome all of you to Shepherd Center. As you heard, I'm a relative newbie, particularly compared to some of the tenure here at Shepherd Center, including our former medical director, Don Leslie, and his predecessor, Dr. David Apple, who was one of the founders and the first medical director here. So I'm fortunate enough to be only the third medical director in the hospital's 43-year history, 44 almost year history, and very proud to be here. Just very quickly about myself, I'm a neurologist and a physiatrist by training. I was about 11 and a half years in the Navy, and then I worked at MedStar National Rehabilitation Hospital in DC for about 10 and a half years before coming down here. And here, in addition to my role as Chief Medical Officer, I do see patients in our concussion clinic and our Share Military Initiative, which you'll hear about in just a moment. This is certainly a very important conference that you're holding today. As you know better than anybody else, post-polio syndrome is a condition that is not widely known or understood by many. So it's really wonderful that you have this opportunity to come together, to learn, and to network. Prior to coming to Shepherd Center, as I mentioned, I was in DC at Minnesota National Rehab Hospital for over a decade, where I had the great honor and pleasure of working with Dr. Laura Halstead, who is one of the leaders in the field of post-polio. So knowing him, and he's also a survivor for those of you who may not know him or know of him, but being able to work directly with him and meet many of the patients that he served over his many years there really gave me a great appreciation for what you're living with today and the importance of conferences such as this. Shepherd's mission is to help people with temporary or permanent disability caused by injury or disease rebuild their lives with hope, independence, and dignity, advocating for their full inclusion in all aspects of community life while promoting safety and injury prevention. While post-polio syndrome is not something that we see every day here at Shepherd, it is something that we do treat here, and it certainly aligns with our mission of giving those who have disability from neurologic diseases as full a life as possible. So I'm going to start us off with a video that includes a short history of Shepherd Center by our founders, and I'm fortunate that we were able to get this to run today, so I think we're in good shape now.
It was an early morning in Rio de Janeiro on the beach, about 10 o'clock. And my two friends and I went out on the beach and we're laying out in the sun, and I got hot and I said, does anyone else want to go catch a wave? And no one else wanted to go in. The third wave I caught was about 10 or 12 feet high. It collapsed into 3 feet of water. I can still vividly remember hitting the bottom and knowing I'd been stunned and hit the bottom and tried to push off the bottom and couldn't push off. And then the next wave went over and I couldn't kick off the bottom. And at that point, the fear set in of, I'm gonna drown.
It was morning, and it was at 10 o'clock. And I was in the basement, standing on a brass bowl that was gonna use in the fireplace and put rocks in there to fire that. And for some reason, Alana was still there. And so when I got this boy's message, I said, Alana, get on the phone. I was down in the basement, I could hollered up the steps to her. And it's that call that you never want to get. You just never want to get it. And I can walk down the halls here, and I can tell you a new parent. I mean, I can see it. I've been there, I look the same way.
You know, it's a call that every family remembers who's ever had some family member injured. It's the call from hell. Injury happened October 21st, and December the 6th, we arrived at Piedmont.
And they had already put together a team of doctors, from a group of orthopedic surgeons to a pulmonologist, a thoracic surgeon, neurologist. So they wanted to treat it as a team because they knew how complicated it had gotten. And we thought if we got back to Piedmont and our family and our doctors, everything would be fine. And it was sort of fine. It was a pretty rocky road. I spent a few more weeks in ICU and had some respiratory arrest, cardiac failure. So it was a pretty rocky landing even coming back home.
There was a lot of doubt about whether he would live or not, as you can imagine. So we heard about the hospital in Denver, and Harold went out there and looked at it and came back that same day and said, this is so different. It's really what they call spinal care. And so he said, let's get out of here. And they said, oh, no, you can't possibly be. No. It'll be six or 7 months. We need to build him up with blood transfusions and all this sort of thing. I said, no, we're going. And then they began to come around one by one to us and say, you're really making the right decision.
And it was just like you flipped a light switch. It was night and day.
He began to move a toe and then a finger or so. And when we got out there, he was coming off his ventilator, and they began to pull all the tubes and get you knowing that there's some hope. and a lot of intense physical therapy and so forth. So lucky that he was incomplete injury, so he got return of function and sensation, particularly on one side. And he was able to walk out with a leg brace and a crutch. Well, that was a great day.
Everybody said, you know, there should be something like Craig in the Southeast.
So, oh, somebody ought to start something, and yeah, somebody ought to start something. Somehow that somebody became us.
Partner of mine who was a friend of the Shepherds knew they were looking for a medical director for something they wanted to start, and he gave them my name, and they called me up and said, would you be willing to consider starting a rehab center? And I knew it would go right from the start because there was nothing available within a short airplane or a long airplane ride from Atlanta.
You know, we begged every friend we knew and some that we didn't know too well for money to buy into this dream. And no one in Atlanta really understood what we were trying to do. So like, you know, would you make a contribution, you know, see if we can pull this thing off. And we started with 6 beds in August of 1975.
It became obvious so quickly that they didn't have the facility to cover all the patients' needs.
It was so wonderful to go in where everything was brand spanking new. The rooms were fully accessible. The facility was fully accessible. And we had a staff that knew how to take care of patients with spinal cord injury in an expert way. So just having your own home was worth it all.
And what's wonderful about this Shepherd is it's not like a hospital. It's not depressing. Everyone has a smile on their face. It's really like they say, like a big family.
Almost every day somebody stops you in the hall of the elevator and says, thank you for starting this place. Well, you know, I'm not the only one that started. There were 4 of us in the beginning, and then lots more people were part of it. I couldn't do anything better with my life.
It's been 40 years. We've had a few bumps in the road, but you're going to do that if you do anything that's worthwhile.
I think one of the things that's most important to me is touching the people that come through the doors here and watching them leave with a smile on their face and hugging staff and saying how grateful they were to have been someplace during one of the most horrible times in their life, and they're ready to re-engage. It's just, it's moving every day.
I love this video because it's so inspirational. I am here this morning or this afternoon to welcome you and introduce you to Shepherd, and I certainly could not do justice to an introduction. I couldn't do it nearly as well as our original founding members. Unfortunately, we lost Harold at age 90 just before Christmas of this year, but Alana, who is 88, is still here pretty much every day. She meets every single new patient who comes in and gets admitted to our hospital. And that's part of what makes it so special is the culture and the family here. Today we're a 152-bed rehab hospital, so you heard that in 1982 they moved to this location, but that was still just the Shepherd building, which is the older building on the other side, and then later they built the current building. So 152 inpatient rehab beds. We specialize in acquired brain injury, spinal cord injury, multiple sclerosis, and catastrophic injury. We treat over 900 patients annually in our inpatient programs. We have a day program for our brain injury and our spinal cord injury patients. The spinal cord injury patients actually come to their day program right here on the 3rd floor. Our brain injury program, we've overflowed a bit, so they actually are at Pathways, which is a mere 7 miles from here. And those of you who don't know, Atlanta traffic means that it could take anywhere from 15 minutes to an hour and a half to get over there. But they spend their whole day there, so they're not back and forth. Some of our other specialty programs include our MS program, which includes 3 and soon to be 4 physicians and 3 advanced practice providers, all specializing in multiple sclerosis. We have an entire team of therapists that do nothing but MS with a very large focus on wellness. And then we have a whole host of nurses who run our infusion clinic, and we do a lot of treatment here as well as a lot of research in MS. We also have a spine and pain institute. We have 2 pain physicians as well as a nurse practitioner, a pain psychologist, and a pain physical therapist who help patients with chronic pain. And you can go and find spine and pain institutes all over the city and all over the country. What makes us different is that while yes, we do treat all patients with pain, we really do specialize in those with neurologic injury, neurologic disease, and treating somebody who has had a stroke or who has post-polio or who has a spinal cord injury and is in a wheelchair and may have other issues going on besides just whatever their pain is are really understood here in our clinic. I will actually only hire physiatrists or rehab physicians who specialize in pain medicine rather than pain anesthesiologists, because I feel like they just have a much more holistic picture of how to manage these patients. In addition, we have other specialty clinics like our wound clinic, our urology clinic. We have an upper extremity clinic with orthopedic surgeons and occupational therapists. We have a spasticity clinic, our complex concussion clinic, and our SHARE military initiative, which is a day program which treats post-9/11 veterans and active duty members who are suffering from mild TBI and PTSD in a holistic multidisciplinary program. Our medical staff is composed of highly trained rehab physicians and neurologists, all board certified in their primary specialty, and most of them double boarded or even triple boarded in subspecialties such as brain injury, spinal cord injury, and pain medicine. We have a consulting staff of about 200 physicians. All of our therapists are specialty trained or doctorate level therapists treating patients really with a focus on what we treat. We really intend to be a very niche neuro rehab catastrophic care hospital and not a general rehab facility. All of our nurses are certified in rehab nursing or will be within 2 years of practicing here at Shepherd Center. Having spent my entire career in rehabilitation, I can say without a doubt that there is no place that affords its patients such outstanding rehabilitation. It's largely through our value-added services that we're able to provide such excellent care. Thanks to the philanthropy through our foundation, we can provide housing to family members that come from over 60 miles away. We also provide housing to all patients and family members that are in our day program, regardless of where they reside. We have 33 recreation therapists. I don't know if you've been in other rehab hospitals, but I can assure you none have that many. Most are lucky to have 1 or 2. Last week, earlier this week, I was down at the Tampa VA, which is a big polytrauma center specializing in spinal cord injury, brain injury. Fantastic program as well. They have about 20 or 25 rec therapists, which is still a big number, but still doesn't compare to what we have here. We offer pet therapy, horticulture therapy, art therapy, and much more for our patients. We have 11 adaptive sports teams, and the SHARE military initiative, which I mentioned before, is largely funded through philanthropy. Those clients get all of the services that they need, including housing, for free to them, regardless of what their payer source is. Finally, to wrap up our introduction and let you get on with what you're really here for today, we have a robust research department, very active in academics. We're clinical sites for physical medicine and rehabilitation training, for PT, OT, speech therapy training, for nursing residencies. Our physicians hold academic appointments at Emory University. And I just have to share something that I never thought I'd be sharing, but my mother ended up being a patient here this last summer. And so I was able to see really what we do on both sides of the bedside, and it really is wonderful. I talked about the rec therapy and all of the other services. We often take patients out on outings. We take patients, actually one of the first things I did when I came here, I went on an outing with 4 spinal cord patients, including one who was a high quad. We went to the airport. Atlanta airport's pretty busy for any of you who may have flown through there. We take them all the way through security so they understand what it's like to go through, deal with TSA, get scanned. We boarded a plane. We actually had the Delta agents transfer them onto the transporter chairs down the aisle and into the seat on the airplane so that they know what they would experience if they have to fly home or if they have to fly any other time. So my mother, who's from Maryland, was fortunate enough to have that experience because she had to fly back home. I also asked her about one of her outings, and she had gone to public library. And I said, well, who else went with you? Was it a big group outing? She said, of course not. Who these days would want to go to a public library? But she loves to read and she loves the library, and so that was important to her. And so that was one of her outings. So it's really individualized care to get everybody back into the community to the highest level that they possibly can and doing the things that they want to do. I mentioned we have 11 adaptive sports teams. So almost any sport you can imagine will help you get back to that type of activity in the community. In fact, even if you didn't play sports before, it's often an opportunity to get back into the community. So I know that this was a very short overview, and I just wanted to really welcome all of you. I hope that you have a wonderful conference today. I hope you enjoy your time in Shepherd. If you do have the opportunity to get around and see a few things while you're here, please do so. If you go down to the GY level right on these elevators, you can see our beautiful pool. Our gym is down there, although I think it may be locked on the weekends, but I know you can at least sneak a peek at the pool and see other things while you're here. So again, welcome to those of you who are from out of town, welcome to Atlanta, welcome to Shepherd Center, and I hope you have a very successful conference.
Thank you, Dr. Yokelson. We are so happy to be able to work with you. I know people come from out of town to come to the Shepherd Center also. So we so appreciate you and thank you so much. Okay. Again, let's give a hand to Dr. Yokelson. And I just have to say, we owe a tremendous thanks to the Shepherd Center for allowing us to have this activity here today. For those of you that don't know, this is where we have our meetings on the first of every month here at the Shepherd Center. So again, thank you. I am going, because of the technical problems we had, I wanted to do a quiz online with you. I'm gonna wait and do that afterwards. I think right now, what I'd like to do is bring up Dr. Bruno so that he can give you his presentation. The only thing is you'll be able to answer many of the questions after you hear this. I wanted to find out what you know already. So we're just gonna put that on the back side. Is that okay with you? Okay, and so we're gonna get you, Dr. Bruno, ask him. And can we welcome Dr. Bruno to the Atlanta metro area? We are so excited to have you here. Thank you so much. Thank you for working with us this morning.
Well, thank these two
Yes.
beautiful.
Let's give a hand to. Where is Lynn? Where is Lynn? Thank you, Lynn. Lynn is the other member of the team that was helping to get this together. So it's thank for dealing with our technical challenges this morning. So are you good to go? Okay. Dr. Bruno, you ready?
Well,
He has laryngitis.
I have laryngitis.
Yes.
Last night, the board, Carol, takes me out drinking. Wake up this morning, I can't talk. Now, for most of you, that's a blessing. So I'm gonna do as much as I can Okay, well, thank you for coming. For since around 2000, when we had done the majority of the research that we had done in the laboratory, the surveys that some of you have participated in, it was very clear by the year 2000 that we knew what was going on with polio survivors. It's not the polio virus, it's not another virus, it's not the D68 virus that's floating around now. Your batteries are shot. And it seemed to me that the most important thing that we could do would be to educate about that body of knowledge that we've been collecting since, well, for me, 1982. And when I would go to a post-polio conference and talk to folks, you know, I'd do an hour-long presentation about this neuron and that neuron in the brain stem. And people would listen politely, would ask intelligent questions. And by this time, there's probably nobody in the room who knows more about PPS than I do. But then what would happen is my hour-long presentation would be done, and there would be 2 hours of follow-up questions. And I thought to myself, why am I boring these poor people with all of these slides when what they want to know is what's going on with me and what do I do about it? So, especially because I sound like I plucked the magic twanger, it's your choice. I can give you a little presentation, or we can go right to questions. Show of hands, right to questions. I like you too. Presentation?
How long is your presentation?
Well, that's going to depend. Could be 5 minutes. It times out to 40 minutes. And I'm going to cut that down so that maybe I can talk at the end of it. All right, let's do a little bit of this anyway. Start again. Those of you, how many of you, by the way, are friends on Facebook with me or in the Post-Polio Coffee House? Well, you guys know that from my holiday card last year, that one of my hobbies is quantum mechanics, specifically something called quantum electrodynamics. And I've been working on a paper. Can you hear me okay? Is this bumpy? Raised up? Is that better? Okay. That's good. All right. So one night I'm working on this paper, and this phrase keeps repeating in my head. Polio electrodynamics. Polio electrodynamics. No, I hadn't taken my medication. Yes, I'd been drinking. But the voices in my head are saying, no, that's okay. There may be something to this. So I thought about it a little more, and I thought, well, how many of you had high school physics? What is electrodynamics? Well, it's exactly what it says it is. There's electricity, and then something happens. You know, you plug your blender into the wall at home in the kitchen, you turn on the blender, the thing spins. Electrodynamics. It's pretty straightforward. So in physics, electrodynamics is electrical forces that make something happen. Nothing complicated about that. But in polio, acutely, and in PPS for you guys now, it's exactly the opposite. It's the loss of electrical activity generated by your neurons due to the polio virus and what's happening with PPS, damaging or killing neurons, that stops things in your body from happening. And there's a picture of our good, our good friend, the polio virus. Here's an example of electrodynamics. One, two, three.
There we go. Can we still hear him, everyone?
Okay. One problem that we have a lot in the coffee house is you go to a doctor, a nurse practitioner, physical therapist, janitor. How much do they know about PPS or polio? Nothing. So one thing that sort of made sense to me is let's come up with something simple that even these cretins will understand about polio and PPS, because I hate to say this, but it's not quantum mechanics. Here's cell phone electrodynamics. You've got your cell phone, the battery is charged, you want to call your friend, you dial the number, the cell phone sends a signal to a cell tower, the cell tower then sends a signal to your friend's phone, the phone buzzes or makes some kind of sound, so that's electricity causing something dynamic. And the voices in my head are saying, well, that's a pretty simple and straightforward explanation of how the central nervous system works. You have a neuron, for example, a brain neuron, motor neuron, turns on a spinal cord motor neuron, and what happens with your muscle? It moves. That's pretty straightforward. A brain neuron turns on another brain neuron and wakes you up. That's a dynamic process. That's pretty straightforward. So that's how the central nervous system works. Here's what happens when you give a cell phone polio. I don't know that cell phones can get polio, but to tell you the truth, the way things are with Facebook right now, I'm sure Mark Zuckerberg is listening to us. And my account will be canceled by the time I get home. So you've got the polio-infected cell phone having no ability to generate an electrical signal. It can't stimulate the cell tower, and it can't turn on your friend's phone. That's polio. That's what happened to you. That's what's happening now to you. Inside your central nervous system cell phones, there's not enough juice to do what needs to be done, to send a signal to another neuron, to send a signal to a muscle, or the part of your brain that activates you, focuses attention, allows you to think of the word that you're trying to find, but can't. Anybody have problems with fatigue, attention, word finding? Anybody forget the name of the hospital that they're at? So, we've got a model with a cell phone that most people who are 6 and older can understand about the central nervous system. We've got a model of polio. If you damage one cell phone, the rest of the system doesn't work. I thought, oh, that's a pretty good example, simple enough to explain polio and PPS. And then I realized there's a problem. And this is something that comes up in the coffee house a lot. My ears are ringing. Is that a post-polio symptom? My hand is numb. Is that a post-polio symptom? And I could go on and on. Does anybody have a symptom like that they're asking themselves, is this a post-polio symptom? What do you got? A numb foot. Rule of thumb, anything that is sensory, that has to do with feeling, your ears, your eyes, your ability to taste, feeling strange things, not being able to feel, has absolutely nothing to do with polio. Because polio is a motor disease. PPS is a motor problem. It's a lack of activating muscles, a lack of activating brain. It has nothing to do with the sensory system itself. So it occurred to me that it makes sense to start talking about two types of post-polio symptoms. What I'm calling direct symptoms, the ones that are caused directly by neuron damage resulting from the polio virus. For example, you get polio, you can't walk. You get PPS, you're weaker, you fall down. Those are direct symptoms. And then there are the indirect symptoms. Post-polio symptoms caused indirectly by the polio virus, in body parts absolutely not affected by polio. Anybody by chance have a sore hip? Anybody by chance just hip? Okay. The bursa in your hip, the shock absorber in your hip, is probably a mess. It was absolutely and completely untouched by the polio virus. So it's good to keep in mind that there are things that are going on that we can attribute to polio directly, that we can attribute to polio indirectly, and then again, you know, the general statement, not everything is PPS. So you're welcome to have some other condition, but not everything is going to be related to either the direct or the indirect symptoms. Well, let's talk about two laws of polio electrodynamics. Everything I'm going to tell you has to do with a man named David Bodian. And I'm not going to go through all of this. Does anybody happen to know who David Bodian is? Oh, thank you. Anybody know who Jonas Salk is? Yeah, difference in the number of hands. David Bodian was a neuropathologist at Johns Hopkins, and he did remarkable things. He is truly the unsung hero of polio and the polio vaccine. David discovered that there are 3 kinds of poliovirus. Not 1, not 2, but 3, meaning how many types of vaccine do you need? 3. David performed over 100 autopsies on people who had polio, not necessarily died of polio, but who had polio, to find out how the polio got into the central nervous system. And he discovered what goes through the mouth into the gut, multiplies in the gut, gets into the bloodstream, and then goes directly for the brain. And then maybe the spinal cord. So everybody in this room had bulbar polio. You may not know it, but as time goes on, we're seeing more and more people who actually have symptoms of bulbar polio or bulbar symptoms. David, with other researchers, came up with a very effective killed vaccine that worked in monkeys. Unfortunately, it was grown in neural tissue. So if you inject monkey neural tissue into a human being, there are immune issues, so they couldn't use that vaccine. But they proved the concept that a killed vaccine could be used to stop a poliovirus infection. And Jonas Salk. David patiently schooled Jonas Salk about polio. Let me quote Jonas Salk's son, Peter. My father had absolutely no interest in polio. He wanted his own laboratory, so that's why they got the money. Every night at 5 o'clock, David's phone would ring in Baltimore, and who was on the other end of the line? Jonas Salk. This went on for years. Not 4 years, for years. It was so disturbing to the family at dinner time that David's wife, Eleanor, called the phone company and had a kill switch put in. She turned the switch off before David got home. Meal was over, turned the switch on, the phone would be ringing. Guess who was calling? Eventually, David gave the vaccine protocol and all of his protocols to Jonas Salk. Jonas Salk then gave those protocols to the 4 men that he hired who were scientists who actually developed the polio vaccine. The bottom line to this is Jonas Salk had absolutely nothing to do scientifically with the polio vaccine. There is a much longer story that I could tell you, but I won't, unless you pay me money. The first law of muscle electrodynamics. This is all from David's work. Paralytic polio is associated with severe motor neuron damage in the spinal cord and brain. This is a duh question for you guys. Like, you didn't know this? Here's one that you may not know, and God knows your doctors and physical therapists are not going to know. Non-paralytic polio and so-called unaffected muscles may be associated with severe neuron damage in the spinal cord and the brain without paralysis. You had to lose 60%, 60% of your motor neurons going to any given muscle for you to have weakness, let alone paralysis. So, when polio survivors talk about, oh, well, I'm using my good leg more. Not your good leg, not your good arm. Everything, everywhere was affected to some degree by the polio virus. And these are slides that you've seen many times before. Up in the brain, there are motor neurons that send an electrical signal down to the spinal cord. Here are 2 motor neurons ready to receive the signal. I think they're Verizon or Sprint, I'm not sure. The batteries are all charged. They send an electrical signal down to the muscle fibers. The muscle fibers contract, and you move. Well, okay. The rest of the lovely slides show you exactly what I just described, that if the motor neurons are killed, the electrical signal is not going to be transmitted, no electricity, no dynamic activity. No electricity coming from the brain motor neurons or the spinal cord motor neurons, the muscles don't work. What are the effects of this muscle law of electrodynamics? Muscle fatigue and weakness are due to failure, and I'm going to say this a lot, failure of the reduced number of remaining overloaded poliovirus damaged spinal cord motor neurons. If you had polio, there's no free lunch. The motor neurons are hurt, and over time, all PPS is those motor neurons failing, and unfortunately, in some people who don't listen to what their bodies are telling them, dying, and then stuff doesn't work the way it used to. Being type A. Any of you type A, hard-driven, pressured, time-conscious, overachieving? The wife is type A. If you ignore muscle fatigue and weakness and just continue activities, or God forbid you listen to a physical therapist who tells you to exercise, you're causing the reduced number of remaining overloaded poliovirus damaged motor neurons to die. Die. One person in the coffee house earlier in the week is in England, which is, from my point of view, a barren country, especially in terms of medicine. And the physical therapist said, "Oh, you know, you've got to do exercise with your muscles, or you'll lose muscle tone." And there was a tone that I had in my voice that I would have loved for her to hear. No, you don't do that. If you look at your cell phone and you know, somebody, God forbid, falls down on the street and you gotta dial 911 and there's no juice left in your cell phone, what's gonna happen to the guy in the street? He's gonna die. If you just have your cell phone and it's on 5%, do you keep making phone calls expecting that after you've made the 13th or 14th phone call, there's going to be more juice in your battery? No. And she knows because she rigged all of this up. This is a slide based on 158 human autopsies, most done by David, some by other researchers. And the important part of this is that the bulb of the brain is most severely and most frequently damaged by the poliovirus. The darker the cross-hatching, the more severe and the more frequent the damage. The reticular formation is the part of your brain that is keeping almost all of you awake and focuses your attention, tells your cortex, your supercomputer, to turn on and do what you want it to do. Dopamine neurons are also killed off by the poliovirus. But there's no more Parkinson's disease in polio survivors than there are in the general population. And we can talk about why that's true later on. But dopamine is the #1 brain activating neurotransmitter. Do you know what drug brain neurotransmitter is turned on when you take cocaine? Do you know what's cool? You all know this, and not one of you is going to answer because you know you're going to get busted on the way home. It's dopamine. Dopamine is king. Any of you have polio feet? Cold and purple feet in the, well, it never gets to be winter here, but you know, when it gets down in the 70s. Parts of the brain that control your body temperature were damaged. And parts of your brain that send the electrical signal from the bulb of the brain up to the cortex to turn things on upstairs were also damaged by the poliovirus. So there's a lot of stuff going on here. You know, it's not just muscle weakness, and it's not just fatigue, which is why David Bodie, when my first time in Atlanta was going to the first Warm Springs Post-Polio conference, at which David presented, and everybody was going back and forth, well, not me, but a lot of people were going back and forth with naming this thing. How many names do we know of the late effects of polio, post-polio muscular atrophy, post-polio myelitis, progressive muscular atrophy? Got to get as much P in there as you can, I guess. And David, you know, being David, just raised his hand and said, why don't we call it post-polio sequela, the sequel to having had polio? Clearly, it's not a syndrome. You can't have a syndrome if he's got fatigue, you've got bursitis in your hip, you've got muscle weakness, somebody else has got all of those, and there's somebody sitting in the back of the room who can't think of the word, I'd like to go to the bathroom now. That's not a syndrome. This is the bulb of the brain. And what's important about this is that in two studies that we did, and showing up now in terms of talk about late onset symptoms. When I first started this, my hair was brown and I had more of it. So, you know, obviously the time is late. The parts of the brain that control your heart rate, prevent it from going too high, prevent it from going too low. Your blood pressure, prevent it from going too high, prevent it from going too low. Were damaged by the polio virus. One thing we talk about in the coffee house a lot, and since we're among friends and you've already eaten, is constipation. Constipation is a post-polio sequela because the vagus nerve, the nerve that is responsible for slowing down your heart, is also responsible for turning on your gut. And if the vagus nerve doesn't work, you're going to have trouble in the morning, afternoon, or evening, which is why there's a post-polio diet on the postpolioinfo.com website to help people get moving, but in a good way. What are the effects of the brain law of electrodynamics? Brain fatigue is due to the brain activating system neuron damage, especially to our good friends, the dopamine neurons. The first study that we did when I was still at Columbia, polio survivors have doubled sensitivity to pain. You guys in tune with that? Why do polio survivors have double the sensitivity to pain as people who didn't have polio? Well, David Bodian knew, but he didn't know. What we did was put together our research with David's. You know what endorphins and enkephalins are? Body's own morphine. Guess what neurons the polio virus attacked? The ones that produce endorphins and enkephalins. So when you look at David's work from like 1949, you see all of these parts of the brain, and he's saying, well, you know, this is damaged, but I'm not quite sure what's going on here. You know, this doesn't work anymore, but I don't know why. And it took, you know, endorphins and enkephalins were discovered at Johns Hopkins, as it happens, and it was only until they were discovered that we realized what David had found. He understood with this combination why polio survivors are twice as sensitive to pain. And poliovirus damage to brainstem areas causes a whole bunch of things that we should be talking about. Shallow breathing, especially at night. Retaining carbon dioxide. We've got to come back to that because people, anybody on a CPAP machine for sleep apnea? No. Bad. And we'll talk about why. Sleep apnea, trouble swallowing, our friend constipation, gastric reflux, too high or too low heart rate, fainting. We found in one of our surveys that in polio survivors, compared to people who didn't have polio, if you fainted once in your lifetime, you have a higher report of fatigue than polio survivors who've never fainted. And those who fainted 3, 4, 5, 6 times have an even higher level of fatigue. So when you, thank you, when you go back and look at what's going on in your brainstem, there's a combination, there's interaction between all of these different areas, controlling blood pressure, controlling heart rate, controlling fatigue. It's an incredibly complex system that's been severely damaged. The good news is you guys are still here. Yeah. All right, so that's it for the electrodynamics of PPS.
Is there anything to help with dopamine? Is there something so that we have more or process more?
Well, maybe. It's,
Dr. Bruno, what are you thinking? If you'll ask your questions in the,
I'll repeat it.
okay.
If polio survivors have too little dopamine, give them more dopamine. Well, I don't know if you've ever heard this, but there are some people who take cocaine once and it shuts down their dopamine receptors and they're depressed for the rest of their lives. Anybody know that? One thing that I started at Columbia with the Parkinson's group, and one thing that I started to learn there, and have learned over time with David's work and with polio survivors, is, and forgive me for this, you don't screw with dopamine receptors. And people will report restless leg syndrome, periodic leg movements during sleep. The latter being a post-polio sequelae. Polio survivors have more of that than other folks. And then they're given a drug called Mirapex, which stimulates dopamine receptors. You don't want to do that. You start screwing around with the dopamine receptors, and the dopamine receptors will shut down because it's like literally like you're screaming at them. Go back to constipation for a minute. A number of our patients have had what's called gastroparesis. Anybody here had gastroparesis where your gut just shuts down? The treatment for gastroparesis is a drug called Reglan. And Reglan stimulates dopamine receptors in the intestines. Blocks dopamine receptors in the intestines. So we have a patient, gastroparesis. This is, I don't know, her second or third episode of gastroparesis. Send her to the ER. Her belly is like she's 9 months pregnant. And the doctor happens to be from India. And it's, well, do an MRI. Let's make sure nothing is going on. Oh, no, I don't have to do that. In India, we give everybody Reglan. And then they make poo. Well, making poo is a good thing. She got the Reglan, and she got Parkinson's. I mean, like that. They came back and they saw her in bed and her hand doing this. And the good news, though, is that her Parkinsonian symptoms lasted about, this is good news, lasted about 10 years and then dissipated. So it took the dopamine receptors that were being blocked 10 years to recover their normal functioning. So again, rule of thumb, if you go to a doctor, and I mean, this is true for any medication, if you go to a doctor and you get prescribed a medication, you ask, what does it do in my body? What are the side effects? What are the potential side effects? Short-term and long-term. Yeah, I know. If my tongue swells to the size of my foot, I should go to the ER. Other than that, how are you screwing me up? Do not take a medication unless you get that information. Because the doctor is going to be like the Indian doctor. Oh no, we give everybody Reglan and they all poo. Yeah, they poo and they get Parkinson's disease. Not such a good thing.
Can I just add, I'm the one that's talking. I've got it.
Oh,
Right.
hello.
Okay. I think I've been in a chair 70 plus years at this point, and dealing with or trying to understand what's going on with us since the early 80s with this post-polio stuff. And I've done a lot of lifestyle changes, but to me, the thing that in all these years, the worst part of this is the fatigue. And the older I get, the worse it gets. And so, you know, I'm like going back to bed every day, virtually, if I possibly can, every day of my life for a couple of hours at least, to kind of, so I have 2 like half days. Anyway, all this is to say, is there anything, any stone that hasn't been unturned at this point about the fatigue?
I wish I had answered your question. We did a study and used a drug called bromocriptine, which is used in Parkinson's disease. And bromocriptine sort of bypasses the dopamine receptors, for the sake of argument. And it was a very difficult study to do because there were side effects of bromocriptine. It was hard to control, do a placebo control on these folks. But we took the polio survivors whom we treated at the Post-Polio Institute, who did everything that they were supposed to do, you know, paced, power chair, brace, crutch, whatever, and still couldn't get rid of the fatigue. And the results of the study is it looks as if the bromocriptine helps. But the side effects of the bromocriptine are such, not Parkinsonian side effects, nausea, for example. It's just, you know, I'd rather take a nap than throw up. That's basically the answer. But the more important part of the question is, if you're fatigued during the day, you must have a sleep study. Do you?
I've used a CPAP for 20 years.
CPAP. That's why you're still fatigued.
My doctor doesn't want to do another sleep study on me, but there's something very wrong. And I know there's something very wrong with me being on the CPAP.
I'll tell you why the CPAP doesn't work. Polio survivors.
Could you come forward so we can see
Hi. You're taller than I thought.
All we could see was this much.
Actually, that's this much too much. CPAP. What does CPAP do? Well, sleep apnea is when your throat closes down and air doesn't get in. So CPAP literally just blows air down your gullet. That's what it does. It doesn't care how much air it's blowing into your lungs. It blows at a certain pressure and keeps blowing all night to keep your throat open. Well, that's okay for the air in part. What isn't it okay for? The air, thank you, the air out part. I don't want to go into a lot of detail about this because it's very sad actually. But polio survivors are known to retain carbon dioxide. You breathe in oxygen, you spit out carbon dioxide. With the CPAP, you can't do that. It's like, you know, your lungs are on fire and somebody's taking a fire hose and just blowing water into your lungs. Well, that's not a good idea. Is BiPAP a good idea? BiPAP, bi meaning two, blows in at a certain pressure, turns off, and then the pressure drops, and then supposedly you can exhale. Well, the pressure drops to around 4 centimeters of water, which isn't a lot, but it's still enough to prevent you from blowing off carbon dioxide. This happened to a patient in North Carolina, went in for gallbladder surgery. They brought her, it was inconsequential, brought her back to the post-op recovery room, and her oxygen saturations are dropping, and they had her on CPAP. O2 is dropping. Oh, well, if your O2 is dropping, what do you need? Oxygen, yeah, so they turn up the oxygen. But now the sats are really dropping. Oh, what do you need? More oxygen. She codes, she's dead. The surgeon actually called me up crying. He said, I don't know what happened. You know, her SATs were down, and he goes through this whole story. And I asked him a simple question. Well, what ventilation were you using? Oh, well, we had her on the XX CPAP. I asked him a couple of other questions, and he said, I killed her, didn't I? And I said, yeah, you killed her. They did blood work as this was going on, and there's a measurement in your blood by carbonate that increases when your CO2 increases. It was literally off the laboratory scale. So what they had done was force carbon dioxide to saturate her body, and it killed her. Well, you know, if you watch The Outer Limits, I'm sure there's an episode where somebody has done that. BiPAP, if your insurance company won't pay for what's called a volume ventilator, they're going to make you try BiPAP. And it should be set at whatever appropriate, you should have a sleep study. During the sleep study, it should be set at an appropriate inhale pressure. And then it should also be set at the lowest exhale pressure, 4 or even lower than 4, sometimes 0, so that you can exhale the carbon dioxide. You call it a volume ventilator. So there's CPAP, BiPAP, not so good, but you might be able to make it work, and a volume ventilator. What a volume ventilator does, it doesn't just blow air down your gullet and then shut off. It actually can be set to the amount of air that your lungs will take, will be able to inhale. And then it does that, it sends X amount of air into your lungs, and then it turns off and you exhale. It's not a fire hose, it's a very precise system. And if, you know, your local pulmonologist doesn't want to do lung function studies, measure carbon dioxide during those studies, send you to a sleep center, do a titration on a BiPAP, and consider a volume ventilator, get another doctor. Better to get another doctor than to die. In my humble opinion. Yes, ma'am.
Is that like when we see sports people, or when I get tired doing a certain task and we want to, is that like getting rid of, are we pushing CO2? Is that
When you're doing a task and you're puffing out air,
Yeah,
that's an obstructive. There are two kinds of lung conditions, obstructive and restrictive. And polio survivors, you know, if you have sleep apnea and you're obstructed in the throat, well, that's obstructive. Polio survivors have problems breathing because their diaphragm isn't moving up and down because the diaphragm is weak, or the nerves in the bulb of the brain are not telling the diaphragm to move up and down. So if you have COPD and you have this obstructive problem, you're literally trying to blow off the CO2 by puffing your way through. And if that's happening, you got to see a pulmonary doctor. Yes?
I had a sleep study. I did not have apnea, but my oxygen level was so low that I've been sent from specialist to specialist to figure it out. Nobody has. So it's because of the vagus nerve? Is that?
Not, you went for a sleep study, you don't have apnea, your oxygen is low.
95% of the time it was like in the 70s.
In the 70s. Not good. Well, the simple questions they ask are, well, if you don't have sleep apnea, if you're not obstructed, is there enough air moving in and out of your lungs? One diagnosis that is often missed in polio survivors is what's called hypopneas. shallow breathing. And you'll hear this from spouses often. Well, does your husband or wife snore? Well, no. Do you ever see that they stop breathing at night? Well, no, I can see your belly going up and down. The question is your belly going up and down enough? So you need a sleep study on a volume ventilator to inflate your lungs. This is mechanical stuff. This ain't quantum mechanics. This is just common sense.
While we're on the subject of sleep, I can never get to sleep, and I took a sleep study and didn't fall asleep until 7 in the morning, and the guy wraps up the subject.
Don't pay for it.
And I don't think I did. I didn't have sleep apnea for that 1 hour, but I finally decided to go ahead and start taking Ambien, because that way at least I do sleep, and I felt better because at least I am getting a good night's sleep. It says there's side effects, but I've now been taking it for over a full year, and I seem to be okay. So, do you have any other cautions I need to worry about, or should I just sleep?
You're not sleeping. You have a sleep study. You talk to your doctor. You have insomnia, not these other conditions that we're describing, and Ambien is prescribed. It's 4 years down the road. You are doing what polio survivors must do. You're listening to your body. You're not seeing any side effects. You're actually sleeping and breathing occasionally at night. Okay. And if you have extra, talk to me later. Yes, ma'am.
Besides post-polio, I spent 3 days in the hospital before Christmas with asthma. I'm also a singer, trained singer, and I'm worried whether the singing is damaging the breathing muscles, the motor neurons that help me breathe.
It's possible. If you overuse, listen, diaphragm is a muscle. You're a singer. You're using that muscle in ways that are beyond what normal people do. You're controlling that muscle carefully, and depending on how long you sing, how loudly you sing, it could be too much. That may just be a simple case of, doc, it hurts when I hit myself in the head. Well, don't hit yourself in the head. Do less. Do less singing. Sing in intervals. Pace. We've talked about that three times before. Yes, ma'am.
I had a sleep study done, and they said I did not have sleep apnea. But I used to wake up, sit bolt upright in bed, not being able to breathe, feel like I'm dying, or I'd have dreams that I was drowning and gasping for air. So the doctor went ahead and gave me an adjustable CPAP machine, so it does reduce. It's not as much as a BiPAP, but it does reduce. I do not have any of those symptoms anymore. So,
well, you had sleep apnea.
but the study said I didn't.
Bad study.
Okay. I asked the doctor that said it, I said, could it have been a bad study? She said, no, you don't have sleep apnea.
Yeah, but I wake up, I can't breathe, I feel like I'm drowning. Other than that, I'm fine.
Yeah, exactly.
Yeah.
I mean, I could feel my throat, just not getting any air. So I need to go, though, to either a BiPAP or a volume ventilator, even though I seem to be doing okay.
Well, again, with regard to the Ambien issue, if you've gotten tested for whatever the symptoms are, the panoply of post-polio symptoms, and you've been given a treatment, and the symptom that you went in to have evaluated is gone, or significantly decrease,
I'm okay.
you can't argue with that, you know?
Okay, thank you.
One more question.
Okay.
Here's one right here.
You and I debated this on your website, and you told me I needed a prince to wake me up.
A prince to wake you up. Yes, I did.
Yes, you
I
did. I'm waiting for the prince.
did. You didn't get the address?
Not yet, but I will. But my question is this: my doctor and my regular doctor passed away, and I'd had him for 20 years. He knew me when I was walking, running. He saw me on crutches. He saw me in a chair, and he wouldn't even know me now. But he passed away. But I stayed with the group that he's with. My problem is I take Xanax. I have that spasms where I'll be sleeping and literally my arms just jump up. And then it wakes me up. I think, why am I doing that? But I really went toe-to-toe with my doctor and said, you either give me the medication I need or that I've been on, or I need another doctor.
Yes.
And he got very angry with me and said, all right, then I'll take care of you. And I was also the one that on the website, he said, oh, I'll get you up on that table. I'll get you up there. And I said, all right, let's go. You know, let's do it. And I got up on the one step and I said, all right, now how are we getting the rest of me up there? And he just got angry again, very angry, and said, I'll just give you your physical in your chair. And I thought, you know what, buddy? I need a new doctor.
Bye-bye.
Yeah.
Yeah. You're bringing, I'm sorry, number one. I'm sorry the prince's address didn't come through, number two.
I'll be looking for it.
Yeah, please. But you're bringing up another post-polio issue, and that is, we did 2 studies, sleep studies, polio survivors. And I don't know who else has this same symptom, but your legs twitch and jump, and your arms or other muscles twitch and jump at night. And as you're falling asleep, they can fly out and hit your bed partner. And you can use that as an excuse. You don't want to hit the prince. And Xanax is the drug that we found that just knocks out the abnormal movements. So, and then you get the doctor, oh, Xanax is an addictive drug and you can't take that. Well, Xanax is used for anxiety attacks. It is a horrible drug, horrible. It has a half-life of like 3 minutes. So you keep popping Xanax all day while you're having panic attacks. Well, if you take 0.5 milligram of Xanax before you go to bed, what are you going to be doing while the Xanax is leaving your body? Sleeping, for God's sake. You're not going to get up every... Yeah, and we've never had anybody... I'm not even sure we've ever had anybody add 2 milligrams of Xanax. But usually 0.5 milligram, maybe if you're a big guy, 1 milligram will do. And believe me, these folks aren't waking up in the middle of the night popping more Xanax. They're sleeping peacefully.
I've always felt like that I forget to breathe. It's not that I breathe in and hold my breath, it's that I exhale and then just don't breathe anymore. Is that the brain damage causing that, or what?
You forget to breathe. This came up in the coffee house.
It was me.
It was you?
Yeah.
Well, thank you. Clearly I didn't answer you.
You did. You told me to have pulmonary studies and check the CO2 levels.
Oh. Well, why are you asking now?
Because I don't know whether it's just me or whether it is actually the brain part that's just not telling me to breathe.
Something is going on that is making you feel as if you have to remember to breathe, and your brain isn't doing it for you. Now, you think back to the iron lung, your brain wasn't telling the diaphragm to move, and
I didn't have.
no, I don't mean you. I'm sorry.
Okay.
But the most parsimonious explanation would be, yeah, there's something going on in the brainstem, and given whatever the conditions are, you have this feeling that you need to remember to breathe, or you need to take a deeper breath than you've taken. You breathe normally, sort of, and you feel, oh, I'm still short of breath, and you have to take a deeper breath. Could it be the brainstem? Yeah. Has anybody ever died of that? No.
If I get aware of my breathing, I can get kind of panicky, and then that makes it worse. So I try to do the mindful breathing and breathe into my belly and calm down. But lately it seems like I have less ability to exhale. The trick is that you breathe out longer than you breathe in, that exercise.
Sure.
I can only breathe out about half of the time that I can breathe in.
You need lung function studies to see what's going on with your lungs. Is asthma a possibility? Is there something else going on? Is your vital capacity, the amount of air in your lungs, decreasing?
So the diaphragm muscles are in control of that?
Oh, yeah, sure. Oh, sure.
So as I'm losing my thoracic back, I'm losing my diaphragm too, because that's what's happening to my back.
Well, the two are not losing. Tell me again, what in your back?
I've always had the low back pain, but now I'm losing the muscles in my upper back. So am I necessarily losing the diaphragm?
Are you bending forward?
It's just hard for me to hold myself erect.
Oh, okay, so that would be the normal position for you instead of being upright.
Yeah, I'm kind of.
So for anybody, if you bend over, you're compressing your lungs, you're compressing your diaphragm, and it's damn hard to breathe. So the stuff going on in your back may be related, but not directly related. As you were saying, indirectly related to what's going on.
Dr. Bruno, with regard to sleep studies, what qualifications or credentials would you recommend that we look for so that we know that people are actually aware of what you are describing?
A recommendation from another polio survivor. Yeah, me too. A recommendation from another polio survivor. That's what's so wonderful about the coffee house. There'd be somebody in, Easton, Washington, and I'm having breathing troubles and I need a sleep study, but I don't know where to go. And then somebody from Seattle will say, oh, well, I went to Dr. So-and-so, it's worth the trip. He listens to me, she knows about PPS. So getting a recommendation is the best thing to do. Their board certification in sleep medicine is not going to tell you anything. And they're probably the number one factor is their willingness to listen to you and what you're telling them, and then think about what's going on, which doesn't typically happen with doctors.
Okay. We've had a lot of explanations and questions about the sleep apnea, but I kind of want to go on to osteoporosis. I've been diagnosed with that,
and luckily I have a really good endocrinologist that is working with me, but they all want to go right along with some kind of medication, and all the medication then comes back with muscle spasms and muscle pain, and then even you can have problems with your joints, you know, in your mouth and jaw, caused from some of these medications. But what do you do about these medications?
Osteoporosis and osteopenia.
I've been diagnosed with the osteoporosis, and I've had one hip fracture.
A spontaneous fracture or full?
The left leg that was affected with polio gave out, and then when I fell, not only on the knee, then I rolled over and it broke the femur neck. So it's got 3 pins in it. Now they're wanting to put me on Post-Polio, and I'm fighting him.
Well, all right, we'll start with osteopenia is decreased bone density. Osteoporosis is really decreased bone density. And actually the number that the doctor gives you is a probability, the probability that you're going to develop a fracture. It's not a measure specifically of bone density itself. It's you got thinner bone, and if you fall down, the chances of your having a fracture are such and such. First thing is you don't treat osteopenia. If you have decreased bone density that doesn't reach the level of osteoporosis, you don't mess with drugs because the drugs are too toxic. But just like statin drugs for cholesterol, there are side effects. And you, in your experience, have a choice. You can talk to your doctor, you can do some research, you can look at the drugs that have the fewest, for example, muscle-related, nerve-related side effects, and then try that drug, and like with the Ambien, you see what happens. You listen to your body. They're moving now from the group of drugs that you would take every day, and then you take them once a week, and now you take it twice a year by injection. Well, it's damn hard to listen to your body and say, gee, I don't want to be on that drug when it has a half-life of 9 months. So it's a difficult circumstance. In seeing 7,000 plus polio survivors over 37 years, I've never seen a patient have a spontaneous hip fracture, in spite of the fact that they have osteoporosis, are not on medication, and full. Because you guys, I used to hear this a lot, what were you taught to do in rehab? Full. So there's something in your muscle memory that allows you to fall in such a way that you don't break a hip. Shoulders, you're in trouble, but you don't break a hip. But you're bringing up, a good point again. You've got to know what's going on. Your doctor's got to know what's going on. The doctor's got to listen to you, and you don't want to get yourself into a circumstance where you're taking a medication that, if it's bad for you, is going to last until next Christmas.
Thank you. I don't want to tax your voice too much here, but I have a question about the neurostimulators for backs, for pain, where they thread the little wires. Okay. Could you just comment on that, negative or pros and cons, of what to be aware of?
Are you guys familiar with the neurostimulators where they'll put an electrode next to your spinal cord, and they implant a little doohickey, and then you control the frequency of the stimulation? Two things. The first thing is you don't treat pain. You treat the problem. So if you've got back muscle spasms and back pain, or leg pain and back pain, whatever the combination is, elbow pain, well, the first step is not OxyContin, fentanyl, morphine, and a neurostimulator. Those are not the first steps. My experience is that of probably, I'd say 60 or so polio survivors, 59 of them had the neurostimulator implanted. And they can do this as a test. It's not a one-shot deal and you're stuck. 59 of them had the stimulator implanted and could not tolerate it. It made them nuts. And I think that's probably related to David Bodian and the endorphins and enkephalins. That you put something electrical in your body that doesn't belong there in the first place, and it's supposed to block pain activity. Your body can't block its own pain activity. And this thing just feels like you're sticking your foot into a bathtub with a plugged-in toaster.
Yeah, but they say supposedly that the pain that you feel in the nerves, they fool the nerves, so by the time the feeling gets to the brain doesn't recognize it as pain.
If that were true, everybody in the room would have a neurostimulator. You again? I want her.
We have a question in the back and then we'll get to her.
Oh.
Hi. For the past 20 years, I've been diagnosed with a low heart rate. And they've ran all kind of tests and could never come to a conclusion why that is. And that this is the first time I've seen on the screen that that's part of the post-polio syndrome.
Not syndrome now. It could be a post-polio sequela.
Say that again?
It could be the result of your having had polio. That the part of your brainstem that's supposed to control your heart rate, or in other cases, blood pressure, for example, will not do what it's supposed to do. If your heart rate is too low, then the vagus nerve activity is too high, which is kind of not the norm for the heart in polio survivors. Well, what's your heart rate?
It can get in the 40s, the mid-high 40s, and that's when the doctors are really like, what's going on?
Does that happen under any certain circumstance?
I think it's like usually I'm probably stressing about something. That was the only thing I can relate it to.
Well, that would be interesting, because normally, if you're under stress, it's up to your vagus nerve to say, now calm down, honey. Get the heart rate down, get the blood pressure down. We don't want a stroke, we don't want a heart attack. So if you're stressed and your heart rate is dropping, God knows 40-something is too low, but it may be that system is overworking. It's not balanced. Typically, we see people who have heart rates that are too high. And we were talking about this last night when I was getting drunk. That a patient who was one of our patients called me up and said, when I wake up in the morning, my heart rate is about 65. Then I have breakfast, and then it's about 95. And then I have lunch, and then it's about 110. And then I have dinner, and it's about 160. And I've been to these doctors, and they don't know what to do, so they're going to send me to Columbia Presbyterian, and they're going to burn out that part of my heart. And what part of your heart are they going to burn out? I mean, this is kind of nuts. Your heart is making, or something is making your heart rate go up and up and up. And since my training is in the autonomic nervous system, this automatic system that controls your heart rate, I remembered that there's this reflex that happens. When you eat, your heart rate goes up. Why does that make sense? Yeah, your heart rate goes up, so you get more blood going to your gut for digestion. Then blood sugar is being released, and you get the blood sugar going to where you want it to go. And what happened with this lady is that she had developed, because of her polio, a new bulbar symptom that I had never seen before. That in electronics is called a follow and hold circuit. Her heart rate was going up, it would hold. Dinner, up, hold, up, hold. Took her off all medication, gave her, you know what beta blockers are? Gave her a long-acting beta blocker in the morning, a long-acting beta blocker before bed, heart rate's fine. So don't let anybody burn your heart out. A pacemaker might be a good idea. Have you ever fainted?
One time, yes. And that was 2017. And I don't know, well, I was told that I blacked out, and about 5 minutes later, I became conscious.
And you weren't drinking with us last night, were you? No, okay.
Now, that particular time, I did have a glass of wine. I did have a glass of wine that day.
Well, you're welcome to join us tonight.
There's a question over here, and then we'll get to
That moment again.
I just wanted to ask, I understand that you can get weak, and as the effects of post-polio begin to kick in. But I have it where I will just suddenly be paralyzed, and I have no control from the hips down. And then it passes, and I can't, it doesn't come every week, it might be every 6 months or even more. And then I've had it where I thought, well, I'll try going to the word is gone. Sorry. Where they put needles in you.
Acupuncture.
I thought I'll try acupuncture. And I thought, well, this will really rev up my system. After I got out of there, I put my clothes on, I walked out in the waiting room, and suddenly I couldn't move. And I was unable to do anything for about 15 minutes until I came back. And at this point, I don't trust myself. I don't, when I go walk somewhere, I'm doing it, I'm weak, but I'm doing it. Or I think I can go up a stair, and then suddenly there's no power anywhere.
Well, my question for you would be the same as the alcoholic lady in the bank. And that is, what were you doing before your legs gave out?
Yeah, I can't find a pattern. I cannot find a pattern. I've been keeping a log of it.
And you don't see a pattern?
And not yet.
Well, are you using our logs, or are you just keeping a log?
Well, I didn't know about your logs. I would have been happy to use them. But I have my own, yes.
Well, email them to me.
All right.
And we'll look through and see if there's a pattern that makes sense.
How kind of you. Thank you.
No,
I appreciate that.
That's what that's what we do.
Question about PPS and Parkinson's. You had mentioned something about that. My husband has Parkinson's and PPS.
Oh, I'm sorry, yes. We call sometimes. We started calling PPS Parkinson's light. Because when you look at Parkinson's patients, especially new patients, the most common symptom they report isn't tremor or rigidity, it's fatigue. You do neuropsychological testing on Parkinson's patients. They have trouble with attention, and they have big time word finding difficulty, the tip of the tongue phenomenon, which you kindly demonstrated for us. You know the word, you got the word, but it can't get from here to here. Why aren't there more Parkinson's patients among the cohort of polio survivors when polio did such damage to dopamine neurons in the brain? Well, there are different areas of the brain that produce dopamine. And there are three basic areas, but the one that's responsible for tremor and rigidity seems not to have been affected by the polio virus, which kind of surprises me, since, as we said, the polio virus is an action virus. It goes after the action parts of your central nervous system. But there just is a higher incidence, fortunately. So Parkinson's isn't a PPS symptom.
No, they tell him with Parkinson's, they want you to keep moving, exercise, and then with polio, you don't. So he doesn't.
Well, range of motion, passive range of motion, going to a therapist would be a reasonable thing to do.
Probably. He can barely walk anymore.
Well, some device to help with walking would be a good thing to do.
He's in a wheelchair most of the time.
Okay. Sitting is good.
Yeah.
I sit most of the time.
Falls a lot too.
And that's one of the follow-up questions I was going to have for you, Dr. Bruno. How many in here actually are involved in the exercise or exercise program? How many actually out? And for those that are not, just thinking about why you're not. We talked a little bit about this last night, but your recommendation for exercising and what's good and what's not good for post-polio syndrome?
Exercise bad, no exercise good. Again, you need to listen to your body. And there are some people in the coffee house who are doing Tai Chi, yoga. That's not exactly muscle strengthening exercise, but it takes some energy to do. Again, for me, it's 37 years down the road studying people who had polio, and it's pretty clear if you've got a cell phone and the battery is at 2%, you don't keep making phone calls and expect the battery to charge. It's as simple as that. And there's business about, maintaining muscle tone. If you don't use it or lose it, come on. If that were true, no, Americans are fat. Americans are fat and don't do much. Not you. Okay, you're fat, but you sing. If lack of exercise, aerobic exercise, muscle strengthening exercise, were so important, there would be very little traffic in Atlanta, because they'd all be dead. People who didn't have polio should be doing stuff. And you guys, mentioned Laura Halstead, who had polio. I get up in the morning, I take a shower, I brush my teeth, I get dressed. I ran a marathon. I don't need more exercise. I just had my marathon for the day. Oh, by the way, now I have to go to work. It just doesn't make any sense. There are all of these, buzzwords and catchphrases that people spill back at you who don't think about what they're saying or know what they're doing, and convince you. Oh yeah, this is my favorite. You ever see the commercial for Prevagen on television? It's you take supplements for your body, take supplements for your brain. Prevagen, originally found in jellyfish. Every time I hear that, I think, oh, well, if it's in jellyfish, then I'll live forever.
Something with no brain.
You turn into jelly, you sting things. Oh, life is crazy.
Okay, there's a question back here, and then we have 2 more questions after this.
I have a question about cholesterol drugs. My doctor recommended that I take something to lower my cholesterol. However, a couple of people that I know of, relatives who've taken cholesterol drugs, experience extreme muscle fatigue or a muscle problem. And I don't want to count down, what I currently have with, or add to it. So do you recommend cholesterol drugs, or if you do, which one?
We went through, cholesterol drugs, statins, help me out here. Lovastatin, Pravastatin, Lipitor, and even B vitamins, which suppress cholesterol production, are all associated with muscle pain, and specifically calf muscle pain. And this is true of not just polio survivors, anybody who takes the drug. And we went through the FDA reports, the post-marketing reports. I looked for muscle pain and any kind of cholesterol lowering drug. And what we found was that there are 2 drugs, Zocor and Zetia, that have the lowest percentage of muscle pain. So, if you're low density, your LDL number is bad, your HDL number is not where you want it to be, talk to your doctor about Zocor and Zetia. And again, you take the drug, and you may want to keep a daily log of your symptoms. One problem is you may keep a log of your symptoms as you're taking the drug, and because you're keeping the log, you'll have the symptom. And that's a common thing. But believe me, you'll know if your calf hurts like it. And if it does, then you write it down, you call your doctor, and you say, this drug isn't working for me. Or I'm taking Ambien. I sleep all day. I sleep all night, but I sleep all day too. And I need to be on something different.
Are Zocor and Zetia statins?
One is not, and I don't know which one. Zetia isn't a statin. Thank you. You're going to finish this up, I know.
Following on to a couple of the questions about exercise and Parkinson's, I've known for years to conserve to preserve. But now that I have Parkinson's, I'm told if I want to delay the effects of Parkinson's, I must exercise. How do I overcome the quandary? Second part of this question, you just mentioned Mirapex as being something that I should not be taking because I'm allergic to carbidopa levodopa. That's what they put me on. Now what?
Well, two things. One is in terms of medication, you're stuck. You need a dopamine stimulating drug or a dopamine replacing drug, and the L-Dopa didn't work for you, or you didn't take it, so you take the Mirapex. You might want to talk to your doctor about another drug called amantadine.
Amantadine?
Amantadine, which is...
I can remember that.
Okay. I think
What
it's being
about the
written.
exercising?
If the symptoms associated with Parkinson's, one symptom is rigidity. And I mean, this is intuitive. This isn't like, big time science. If you have a big muscle, a guy with a big muscle, and a guy with a little bitty muscle, and they both have Parkinson's, which one is going to have more rigidity? The guy with the big muscle or the guy with the little muscle?
Little muscle, I would guess.
I'll give you a second chance. Well,
Let's try the big muscle.
yes, you're right, the big muscle. Sure. The thing is too big, and the brain is going to say, oh, look at all of these muscle fibers. I can turn them on and I can stop him from moving. But what's important in Parkinson's is not that you're strong like a bull, it's that you can move in a fluid kind of way. And that's what we were talking about, range of motion.
Balance. And maintain balance. That's what most of the exercises they've given you is balance exercises.
Maintain your balance.
Yes.
Well, and it's important, and this is true for all polio survivors. People report balance problems. I'm wobbly. Are you dizzy? No. Are you lightheaded? No. I'm wobbly. Well, one thing that probably people don't test for when you go to the doctor is your hip muscles. The muscles that move your hips out, muscles that move your hips in, the muscles of your low back, your girdle on the bottom. And if they get weaker, then your ability to keep your upper body stable decreases. But then the question is, you had polio, you've got post-polio stuff going on, you have Parkinson's. How strong do your hip muscles really need to be in order for you to have good balance? And maybe using a rolling walker is a better choice than doing hip muscle strengthening.
Okay, there's a question back here.
Is there any correlation between PPS and MS?
A correlation between PPS and MS? No.
I have a question, I can't raise my hand, I'm sorry.
You don't have to raise your hand.
This is a question about your blood pressure.
And you had mentioned this earlier, that the part of the brain that controls your blood pressure / everything else. Well, I have a ongoing many-year battle with my blood pressure, and I can't keep it down, and then, it'll be steady for a while, and then it just goes out of control. And I've been on every blood pressure medicine that you can name, and, it's just a process of eliminations. And I can't take channel blockers, which is recommended by you. I have tried for years to make a correlation with polio / blood pressure, which it really doesn't make any difference at this point. But is there anything that I could possibly do new?
In order to talk about what may be going on that's causing your blood pressure to spike, and then doing something to make it go down, I would need logs of what you're doing, what your pressures are, your pressure lying, your pressure sitting, your pressure standing.
It tends to shoot up when I'm doing nothing. And this is what the phenomenon is. Because when I'm active, it stays. And active to me is not, walking or running, but just active. It seems to be more under control. And at night, when I'm sitting and watching TV, and it suddenly shoots up.
Okay, all right.
Did I hear you say that B vitamins are somehow negative for people with polios?
B vitamins can cause muscle pain. We were, in terms of the statins and controlling cholesterol.
I'm talking more like B complex or B12, and we've just been taking that because it's, they sell it, it's cheap, it seems like you're supposed to take it, so.
Well, if you're taking it for cholesterol and you don't have muscle pain, you're okay.
Not for cholesterol, we just take a lot of vitamins.
Oh, well, okay.
But there's not been any negative effects. If that's something we should watch out for. And we're not talking about mega doses. I'm just talking about, just regular supplements.
Listen, your body is going to tell you if you're taking something and it's not good for you if you're listening. But going back to what you're describing another patient that we've had recently whose blood pressure goes through the roof when she lies down, and then she passes out and she stands up. And that is directly related to what we were talking about with the brainstem and the heart, the carotid arteries. So if you send me an email, and if you can take your blood pressure in the morning before you get out of bed, and then sit up, wait 5 minutes, and take it again, that may tell us the whole story. I'm not sure I can answer any more questions for you. Last two. Oh, my.
I just want to thank you. This question and answer period, I don't think was part of the plan, but that's obviously been the need. And a comment as far as exercising and PPS. I do, the class I take is called Gentle Movements in the Water. And it's a modified Tai Chi at a local community pool where I live. The pool is around 85 degrees, walk-in ramp. They have a water wheelchair. And I do it mainly for stretching. They do a lot of core strengthening exercises. Some of them I can do, and some of them I can't. But I just modify it to what I can do, and that has helped me tremendously. Gainesville, Georgia. But if you look around in your community, ask for an arthritis class, gentle movement, something like that. They offer the class 5 days a week. I find I can go 2. Otherwise, I'm tipped over the edge. So something to check out.
That's a good point. Whether you're from Kentucky or Tennessee or I love you, but too close. California or wherever you. Oh my God.
You're just too close to the
Wherever you're from, you might want to check out what the arthritis organizations or foundation is doing, because we had a presentation from them last month, and they had some very good resources in terms of exercises that were helpful for post-polio. So you might want to look at those also, and you were talking about the arthritis there.
That last question.
Last question, where is it? Wait for the mic, please.
I know that I'm probably one of everybody in here with neck and shoulder pain. So my question is, if you put your rehab cap on, would posture correctors help that, help alleviate some of the tension in the neck?
Neck and shoulder pain, but with posture, good posture, I don't, absolutely.
They're inexpensive, everybody. They're like $28 online.
What's 20?
A posture corrector. It holds your shoulders back and your neck repositions.
We were talking about breathing and posture. I'm not connected to anything. Here's my posture lesson for the day. You know, if you're sitting like this, you're not breathing. Not that I'm breathing anyway. And your head, which is heavy, is pulling on the muscles of the back of your neck and pulling everything forward, which is going to make these muscles go into spasm. Depending on, and I'm not going to ask for a show of hands, but some of you have one butt cheek that is bigger or smaller than the other. So you're sitting like this and typing all day. The best thing you can do, Carol Bear said, best that you can do. The best that you can do is fall in love.
We're gonna switch to handheld, just are you okay with that? Because I don't know if there's a frequency problem. Can you all hear him okay on his? Okay, I just wanted to make sure.
Lots and lots of people, I mean, pain is a big deal. And neck pain and upper back pain and back pain in general are big deals. What's important is to know where the pain is coming from, which muscles are turning on. Is it the muscles in the back of your neck? And then you buy this thing on Amazon and it pulls your shoulders. Well, that may be great, depending on which muscles are in spasm. If the muscles between your shoulder blades are in spasm, and you put this corrective vest on, and it pulls your shoulder blades back, what's going to happen? The muscles are going to shorten, and they're going to go into spasm even more. So our rule is don't feed the spasms. Don't do something posturally that is going to cause you to have more trouble than you already have. And be very specific in terms of which muscles are going into spasm. So you don't go to the doctor and get, not that this would happen anymore, but 10 milligrams of Valium, and what you really needed was something for the disc in your neck that's screwed up. But,
I'm going to have to kind of close down in a minute, but Dr. Bruno is going to be here and be able to take some other questions, but there's some things that we need to do before we close out this. Is that okay? And we'll give you an opportunity to address other questions, because the main reason you're here is Dr. Bruno, right? And so we have a few things that we need to do before we close out today, and I want to make sure that we have an opportunity to do that. Is that okay?
Yeah, the butt cheek issue, if you're sitting like this, the muscles on this side of your body are going to go into spasm. If you have scoliosis, you know, the muscles are firing on the other side because the muscles are firing on this side, pulling you out. So you put in a butt lift that lifts your cheek up so that you're sitting flat. So there are a lot of simple mechanical things that occupational therapists are very good at. They'll be on sale in the lobby for $49.95.
Thank you, thank you. Thank you so much, and thank you, Dr. Bruno. This is fantastic. That is really great. We'll give him a moment to rest before taking on any more questions that you might have, or having some time to chat with him personally. Just be fair and give him a little room so that, you know, he's not just all of a sudden swamped, but we do want to give you an opportunity. This is a special time that we all have. I wanted to, before we have a chance, I want you to have a chance to talk a little bit more with one another, but I wanted to bring some attention to your name badges that all of you have. You'll notice the purple ribbon on there, and you notice a lot of purple around here that we have it. For those of you that didn't know, did a little research and found out that the post-polio color is the deep purple. So that's good to know when you go back with your groups and share that. And so we've adopted this purple ribbon that you see on here, and the polio survivors have the dark ribbon. It's a faded one behind. The story with our symbol, our logo, is you'll see the APA symbol on here for this conference, and you'll see the dime, and there are dimes on the table as part of the decoration for Franklin Delano Roosevelt and the work that he did with polio. So we wanted you to know what this symbol meant and recognize it. So I want to thank the committee and the people who thought about this and put this together. I thought it was rather unique. I hope that you do too, and that you take that back and share it with the people that you know. So I wanted to share that with you. Also, any of the board members, well, all the board members, if you can, either stand or raise your hand so people will know who the Apple board members are here, please. So, thank you, board members, very much. We want to thank our sponsor. He's going out the door there, but the